Good afternoon, one and all. I'll be presenting two case series on the acute CSCR in pregnancy, on the update and on the etiology, diagnosis, and management. So, as an introduction, CSCR is an accumulation of subretinal fluid at the macula, which presents as a circumscribed area of serous retinal detachment. Pregnancy being a risk factor because of endogenous hypercortisolism. So the first case details are patient 31-year-old female in second trimester, known case of diabetes, presented with history of blurring of vision in the left eye for 2 days. BCVA in being 6.9 and fundus showing circumscribed area of localized serous detachment at the macula. Diagnosis being confirmed by OCT, we came to the conclusion of CSCR. 4 weeks later, the patient's BCVA was 6 parts, and we could see resolving CSCR with organized subretinal fibrin confirmed by OCT. Second patient, 26-year-old female, again in second trimester of pregnancy, complaining of blurring of vision in the left eye for 1 day. She was just a known case of hypothyroidism. On treatment, we can again see localized area of serous retinal detachment at the macula. BCVA being 6.9, diagnosis was confirmed by OCT. 4 weeks later, we can still see retinal detachment being present. However, it has reduced. 8 weeks later, it has reduced. Patient's vision is 6.6, and some subretinal fibrin accumulation can be seen. Systemic workup for the patients were within normal limits. BP was normal. There was no evidence of proteinuria. FFA was not done since it was an acute presentation, and also as a precautionary measure since the patients were pregnant. Discussion. So coming to the proposed causes for CSCR in pregnancy, hormonal alterations are considered to be the main risk factor. Increased corticosteroids. Also there is increased there is impaired autoregulation of choroidal circulation, which gives rise to alteration of the blood retinal barrier choriocapillaries in RP, leading to increased permeability, precipitating CSCR. Other mechanisms proposed are hemodynamic alterations, decreased colloid osmotic pressure, hypercoagulability, and changes in prostaglandin levels. Clinical course, it most commonly presents in third trimester, since third trimester has the highest cortisol levels. However, in our patients, we noted it to be in second trimester, and it mostly resolves by 4 to 8 weeks postpartum. Subretinal fibrin has been seen associated in 50% of the cases of CSCR in pregnancy, according to literature. Coming to recurrence, the patients have to be warned about the recurrence of CSCR in subsequent pregnancy and to present as early as possible. These are some literature review in which patients present, CSCR was there in the 6 months in first pregnancy, and CSCR recurred again in 6 months in the second pregnancy after 2 years in the same patient. Differential diagnosis, toxemia-induced retinopathy and posterior scleritis can be kept as a differential diagnosis. However, they were ruled out since there were the patients did not have any toxic features, and there was absence of proteinuria. As for posterior scleritis, there was no complaints of pain. The B scan was normal. These are my references. Thank you.
So in these two patients, both of them were having first attack?
Yes, sir. First, they were first pregnancy and first attack.
Okay.
Nicely documented. So
Thank you.
how are you going to warn them? Are you going to communicate with their obstetrician? What are you going to do when you see such a patient?
Regular BP monitoring was advised, ma'am, first of all, and renal function tests were done. However, the patients improved by 8 weeks presentation ocular-wise. However, the patients are still in follow-up with us. They have been advised of about 6 monthly. Now they have delivered and they are doing fine. They have been advised of 6 monthly follow-up with us.